All right, good afternoon, everyone, and welcome. My name is Catherine Kosin, and I am the Volunteer and Membership Program Manager at Chevy Chase at Home. For those who are not familiar with us, we are part of the nationwide Village movement, in which neighbors get together with their neighbors to help seniors in their communities age in place. So for the Chevy Chase area, we help our members with volunteer services like rides to medical appointments, tech support, changing light bulbs. We also have social opportunities, clubs, educational programs, some of which are open to the wider public, such as this one. To learn more about us and our other upcoming public programs, please visit www.chevychaseathome.org. We are so glad that you could join us for this 7th installment of the Navigating Life's Journey series, in which we've discussed how to navigate your options for each stage of aging. We've covered a lot in this series since last November, from building a life plan to age in place to skilled nursing facilities. And now, today, we will explore what to know and consider when it comes to the end of life's journey. Our knowledgeable panel of experts will examine palliative care, hospice, grief support, and death with dignity. I now want to introduce my partners in this series, Angelique Jackson and Kiersten Parsons, who will be moderating the panel. Angelique Jackson, LPN, is the Manager of Marketing and Business Development at Charles E. Smith Life Communities. She has been a nurse for over 16 years, serving in the areas of post-acute and hospice care. Kiersten Parsons, MS, RDN, CDP, is the Director of Healthcare Sales for Ingleside. Kiersten has worked in senior living for the past 11 years, 4 years of which have been with Ingleside. Most recently, Kiersten served as the Independent Living Administrator for Ingleside at Rock Creek. She started her career in long-term care nursing. So as a reminder, this is being recorded, so please make sure you are muted except when you're asking a question, which will be at the end during the Q&A. And you can also submit questions to the chat at any time, which we will try to cover during that last half hour. So Angelique and Kiersten, I turn it over to you. Thanks again.
So we are so happy to be here today, and it's always our pleasure to invite some of our colleagues from the field, people that Angelique and I have worked with, who have been in these different capacities, to share and have them educate each and every one of you based on their area of expertise and specialty. So I do want to invite each of our panelists on this call to come off mute, introduce yourself. If you can just share what your role is, some of your years of experience specifically in this capacity, or how you are an expert on this topic, and then we'll get right into our questions.
I will start. I am Donna Gayles from Capital Caring Health. I have been with Capital Caring Health for 10 years and in hospice services overall for the last 15. I am the Client Relations Director for DC for Capital Caring Health, as well as the Associate Director for our Center for Health Equity. I am very passionate about end-of-life services and am so glad to be a part of this conversation today.
My name is Maria Kaplan. I'm a clinical liaison of JSSA Hospice. I'm a nurse liaison. I used to work in suburban hospital in acute care, and I 6 years and I 10 years in a hospice field. Sorry, Dr. Miller, you.
Okay, I'm Dr. Susan Miller. I've been doing geriatric medicine in Montgomery County, Northwest DC for over 25 years. I'm a former medical director for JSSA Hospice. I did a geriatric fellowship at GW University Hospital in the past, and I was known for doing home visits, assisted living, and nursing home practice. For the last 6 or 7 years, I'm associated with Bethesda Nutrition and Wellness Solutions, which is a patient-centered medical home. We have a team of medical professionals and others, such as social workers, dietitians, therapists, behavioral health support. And we're trying to offer all-encompassing care for adults as they age. And I am also very passionate about end of life care and am kind of known for taking care of frail elderly.
I'm Bridget. I'm with JSSA Hospice, and I'm a social worker and bereavement counselor. I've been doing hospice social work for the last 4 or 5 years in the DMV within DC and Maryland. I've had some previous experience with palliative care inpatient, and again, as everyone I think here is very passionate about supporting our population and all the community members in this type of care, and making sure everybody has a good understanding and feels comfortable talking about these topics.
Hi everyone, I'm Dana Olson. I'm the chaplain, director of spiritual life at Ingleside at Rock Creek. So knew Kiersten through her roles here at Ingleside. I've been at Ingleside at Rock Creek for almost 6 years. So I've been supporting resident staff, families, volunteers in various ways here at Ingleside across the community, from independent living to our higher levels of care like skilled nursing, assisted living, memory support, supporting residents through activities, worship services, whether led by me or outside contracted services, volunteers, doing one-on-one care, but then especially grief care, care at the end of life, and helping residents and families, especially toward the end of life and afterward, continue to get support in various ways.
Thank you so much. Okay, did I miss anybody? I think. All right, so I am going to kick us off with our questions, and Dr. Miller is one of my relationships, someone I know through Ingleside. As she shared, she joined the practice Bethesda Nutrition and Wellness Solutions about 5 years ago, and that practice is on site at Ingleside at King Farm and Ingleside at Rock Creek. And so as she mentioned, they have a team approach to care there, social workers, dietitians, physicians, physical therapists. I think there's other practices I'm forgetting, Dr. Miller, but it's a great group, and it's a special relationship to have Dr. Miller in our communities. She gave a great lecture probably a year ago on death with dignity, and just made some incredible connections and points that stuck with me, and I know was really meaningful to our resident population. So I invited her to join us today, and I think she's going to kick us off from her experience. If Dr. Miller, you can just give us an example, and hospice versus palliative care, what do the two mean? What are the differences between the two? What are the services that are provided within that? And if you get overwhelmed, audience, we're going to, break down each question a little bit more thoroughly.
Okay, thank you, Kiersten. So what I wanted to, I'm a big picture person, so we'll start with the big picture, which is palliative care medicine. That is actually specialized medicine that focuses on providing quality of life by relief of symptoms and disabilities that can be associated with having chronic serious illnesses. So it's not just for people actually at the end of life. Whenever anyone is diagnosed with a chronic serious illness, it's palliative care specialists can work hand in hand with their other specialist and their primary care doctor to try and mitigate unpleasant symptoms and suffering that can go along with having chronic diseases. So cancer is the first thing that pops into people's mind for palliative care, and palliative care works side and side with oncologists at providing curative care and such by trying to help manage symptoms that can really impair a person's quality of life, everything from pain relief, fatigue, to having a team of palliative care members that help with psychosocial issues as well as with physical suffering and such that can go along with having a chronic serious illness. Other things that fit into this category are lung disease like COPD or heart failure. A lot of the neurodegenerative diseases like Parkinson's, MS, dementia would also fall under this. People that have end-stage kidney disease and on dialysis can get palliative care. And it's really a concept of focusing on the patient as a whole, a holistic outlook to try to help people manage what life has thrown at them. And often we hear about palliative care at the end of life because that's when these illnesses are really affecting a person's quality of life and causing a lot of disability and a lot of physical and psychosocial issues. Hospice is actually, and as a physician, I kind of look at it in this way, hospice is actually an insurance benefit. So Medicare and many commercial insurances have what's called a hospice benefit, whereas if the doctor certifies, and often it's two doctors have to certify that someone has reached the very end of their life where curative care is no longer feasible or no longer desirable, and that person, if the disease runs its natural course, is probably going to die in the next 6 months or a year, then that they can trigger their hospice benefit. And there'll be a lot more said about what hospice covers and what hospice does. But the focus on hospice is to help someone, and it's a village type of approach where you have nurses, social workers, clergy, physicians, all sorts of people helping a person, volunteers as well, helping someone deal with the fact that they've reached the end of life, that they're going to, and help them exit this life with as much dignity and respect and comfort as possible. So I guess the other way I'd like to look at all of this is that life is a journey. So it takes a community or a village to bring a child into this world. We do a lot of prenatal care when someone gets pregnant and a child's going to be born. And I see hospice as the same concept, but at end of life to help someone exit gracefully from their physical life, because life, death is as much a part of life. And we just have to accept that. We don't have a lot of control over when we're born. We don't have a lot of control over when we die, but we do have some control over the journey that we take, and we can try to smooth out that road as best as possible. And that's what palliative medicine really does. And I think that we'll just get into the questions so you can understand more. Another way of looking at it is palliative care is kind of like the big picture, and hospice is this very small picture, really focused right at the end, at when someone's death is more inevitable. And I will turn it over to my colleagues.
Dr. Miller, thank you so much for such a wonderful overview of both hospice and palliative care. And explaining the differences of the two and what stage of life they are needed. My next question will be to Maria, who is a hospice nurse. Maria, can you tell our audience who is eligible for hospice care, and do you need a physician referral?
Hello. So Dr. Miller, I really love your comparison of death and birth, kind of how important it is. For me, hospice is also philosophy. It's not necessarily should be death sentence, because we have like 10%, I think, or 15% of patients who survive 6 months or more. And sometimes they even discharge from the program, they becoming better. So it's more philosophy when the family or patient by himself or herself making the decision that they want to be comfortable. They don't want to go to MRI, CAT scan machines. They don't want to go to the hospitals. They would like to stay at home. They would like to have some medications for conservative treatment, but they want to stay as long as possible until the very end at at home and comfortable. So speaking back to Angelique questions about eligibility. We do need doctor order to admit the patient for hospice, because as Dr. Miller mentioned, 2 doctors has to certify that this person has 6 months or less life expectancy. But for information session, like we're doing for you right now, we don't need doctor order. So sometimes we get in calls from doctors, sometimes we get in calls from patients, sometimes from their family members who would like to get more information about hospice. And our nurse comes, registered nurse, and she is doing an assessment. First part of this assessment is eligibility criteria. Does this patient meet eligibility criteria because it's covered by Medicare or other medical insurance? It's a medical program, so there is certain medical requirement, which I touch base in a few seconds. Second part, the nurse gives information about hospice care and services, some probably restrictions, some philosophy, and see if family or patient agreeable to have this program. If both parts coming together, patient wants this program or family wants this program, and patient is medically eligible for the program, that's when we call the doctor, if it wasn't a doctor referral initially, and discuss the case, and doctor agreeable or not with the hospice referral. So eligibility criteria for hospice, medical eligibility, it should be some chronic disease like dementia, because it's a chronic and unfortunately terminal disease. And sometimes people saying, oh, my mom is very healthy, she just has dementia. Dementia is a terminal disease, which eventually killing the people. So it should be it can be some other chronic disease, cancer, heart failure, any other heart diseases, Parkinson's. So it should be a few chronic disease, which one chronic disease which comes, or several, which come into the end stage. And it should be other symptoms and other signs that this disease in its end stage. For example, with people with dementia, it can be decreased appetite, people not verbal any longer, they're not talking too much, just few words. They completely depend on every daily activity, like even feeding. They start to lose weight. Weight is so important for us. And when I'm coming to facility to do eligibility assessment, I start to dig weights around, and sometimes they're very confusing data, which does not let me admit the patient to the hospice care. So this is for dementia. For heart failure, it can be shortness of breath, oxygen dependence, multiple hospitalizations with congestive heart failure. Parkinson's disease, for example, it can be difficulty swallowing, some decreased functional level. So this is a lot of signs and symptoms which given us a clue, and to our doctors and to attending doctor, that it's probably a good idea to talk about comfort approach. And again, there is no obligations. We just come in and we do an evaluation, we discuss all pros and cons, and people making their choice. Some people prefer to die in the hospitals, some people prefer to go with hospice.
Thank you so much, Maria. We're going to ask some more nuanced questions, but I think what we've heard so far, just to kind of recap, I see in the chat that some joined us a few minutes late, thinking of palliative care as an approach in this umbrella term, hospice specifically as something that it doesn't happen automatically. That's a benefit that, two providers, two physicians need to order for you. So that's what we've heard so far. One of the things that I think is a common question when we're talking about hospice is, does that mean that we've given up on life and that we're not going to go to a hospital? We're not going to take any more medications. I mean, what does it mean? So Dana and Donna, if you can just share with us when someone is accepted to hospice care, meaning their physicians have written that order and they're approved and they've gone through the eligibility process that Maria just described, does that mean they're giving up on life?
You know, that's a really great question because it's a common misconception that when a person elects the hospice benefit, that they're giving up. That is absolutely not the case. It is a person who has decided that their quality of life is the most important and that their focus is different. They're no longer focusing on curative care. As Dr. Miller said, when a person is electing the hospice benefit and wanting to have that comfort at home, they're able to not just receive the services that they need at home, but they're more comfortable by being surrounded by those who are caring for them that they're familiar with. It allows them to be in their home setting. A lot of people are most interested in aging in place and not going to another place for care. So the short answer of, is it giving up? Absolutely not. It's actually giving more hope that the journey will be the most comfortable that it can be. Doesn't mean that they're not going to be able to go to the hospital. Because it is an insurance benefit, as was explained previously, a person is not able to receive both hospice and hospitalization at the same time. So if a person is receiving the hospice benefit and does decide to go to the hospital and is admitted, then they would be discharged from the hospice program because it would then be a duplication of services. Doesn't mean that person isn't able to come back onto service after they've been discharged from that hospitalization. In fact, they are able to. Hospice is not a one-way street. A person is able to elect the benefit, or they can decide, you know, there's a new treatment option. I want to pursue that as well. So let me just revoke or remove my election of benefit and go this other path. The person who's receiving the care and their family are always in the driver's seat. There's no giving up anything. It's actually taking more control of the journey and doing what's best for that person and their family. Dana?
Thank you. Yeah, and just really supporting Donna in what she's saying and thinking of it less of giving up on life or giving up in general, and thinking about what's being gained, gaining support, gaining care, and especially with the team that hospice has around it to really support someone in all aspects of their life and their living, especially when it does come toward those last 6 months or who knows how long. I've seen it where a resident has come on hospice, and they've received support in so many ways, spiritual, psychosocial support with getting the comfort they need in medicine toward comfort, that they actually, I've heard the phrase graduate from hospice, and where it doesn't seem for them, for their family, they choose not to be on hospice for a while, but then can come back onto hospice at a later time. So less so giving up and more so gaining support, more of a support system, and being able to focus on their life and living well and what that means for them, what's meaningful for them, and getting the comfort, the care, the support, the relationships, and even just being able to have support and knowing what they want toward the end, in reaching out to family and having that time and that space to be with loved ones and surrounded by what makes life meaningful for them.
For sure. And just to add to that, it's a partnership. No one is giving up their primary care physician. No one's giving up the things that are important in that particular part of the journey. A hospice medical director is involved in the care as a part of the benefit, but that person is collaborating with the person's primary care physician. So many people have the idea that if they elect the hospice benefit, they're losing their doctor. They won't be cared for by the people that they know and that they've come to develop relationship and rapport with. That is not correct. That person will remain with their primary care physician if that physician so desires, and certainly will be supported by the team, which Dr. Miller did explain earlier, includes the doctor, the nurse, the certified medical assistant. It actually helps with the volunteer services, the whole team, the chaplain for non-denominational spiritual support. It allows for us to all partner together with the family to empower them and support them the way that matters most to them.
So helpful. I'm just going to recap for us and make sure we caught everything. So, we heard Dana say that someone can graduate from hospice, just meaning that that is a diagnosis that's the physician saying, within 6 months, we're thinking that this person is going to pass. So if somebody did not, then in that sense, they could either maybe be rejoining hospice once again, or quote unquote, graduate from hospice. We also talked about going to the hospital for care. So that's something that can occur, but just to understand that if you were admitted, then that would be in conflict with the hospice order or diagnosis that you have, or the receipt of that benefit. Donna, I don't know if we touched on, do you discontinue all medications and treatments, or can you continue? What does that look like?
That too is a great question, because there are some medications that a person may be taking prior to their decision to elect the hospice benefit. There's a reconciliation of the medications and a review to identify what medications are still helpful, what might be harmful at the point, or what might not be as beneficial. So it is not automatically stopping all medications. It's a discussion about what's actually most helpful for this movement forward. And of course, that changes. It's very fluid, because it could be that there are medications that are not currently in place that become a part of their regimen. So it is really looking at what's needed at that time and what's most helpful to maintain and support the comfort that is ideal and paramount in hospice services.
Thank you so much. And I think I heard you and Dana both say, if a new treatment option comes out, and an individual wants to discontinue hospice services, that they can do that
at any time. And they could change their mind the very next day and say, you know what, it's going to be too much on my body. I don't think I want to do this trial. I got the information and now I'm thinking I don't want to do it. They could come right back on. It's really up to the person and their family. So it's definitely something we want people to know and understand that they're in control of. It's not a contract. You're not locked into it. It's really a benefit to help serve and support at a critical time. And I agree with Maria, as she mentioned, the hospice philosophy is a way to care for a person who is really advancing in an illness. So definitely not locked into anything, just really being supported in the ways that are valuable to that family.
Thank you. And now I want to pivot again. I know Dana, Donna, and Dr. Miller all mentioned the hospice care team. So my next question is for Maria. How often will someone from the hospice care team visit? How long does a typical visit last? And what support do you offer to your patients and families in case of an emergency?
Okay, so when admission happens for hospice, there is admission nurse who comes to do admission. This is your one-time nurse, because she does only admission and she reviews medications like Donna mentioned, recommend any other medications, talk with the doctor, everything in the system. Next day, usually the patient will have follow-up visit because it's a kind of fresh patient for us, and we are pretty new organization for them and new philosophy. And so we usually doing follow-up visit next day to see how patient and patient family is dealing with, and how what is their condition and how we can help. After that, the family and patient will meet the team, hospice team, and it's a registered nurse whom we call case manager. It's a social worker, it's chaplain. We are Jewish agency, but we have all chaplains of different religion and to support different faiths, and CNAs, which is certified nurse assistant for personal care, and volunteers. And definitely we have our medical directors who working together with attending doctor to make this patient comfortable and meet medical and comfort care needs. So how often? So then it's case by case decision. Nurse or case manager can be there once a week as the minimum, and every day is a maximum. It can be absolutely different cases. Some people very comfortable, they have a lot of support at home. They don't have any comfort needs. They are pretty comfortable what they have. They don't have the stress and symptoms. So the nurse can come, like, let's say Monday, and Tuesday you can call, or Monday you can call if something goes wrong. But she will do probably follow-up call or visit. Versus the patient who has a lot of issues going on. It can be pain management, it can be constipation, it can be shortness of breath, vomiting, nausea, anxiety, fears. And in this case, nurse can come, or some wounds which have to be cared and treated. And in this case, the nurse can come every other day, every day. Depends, and plus as many times as you call her to come, or him, and ask to come because there is some crisis situation. So it very much depends on the case. Same with the social workers and chaplaincy. There are people who are very confident, very calm, accepting what's going on, and there is no stress or crisis situation. I had patient in Sibley, 35 years old, with a small kid at home, and social worker was together with admission nurse to start the social worker care right away because family needed a lot of support and there was a lot of grieving goes on. So this, and I'm sure social worker and chaplain in this case come in probably also very often, up to the every day, if there is a crisis there. So speaking about nurse assistant, it can be 2-3 times a week visit. For 1.5 hours, probably CNA come in 2 hours to do some bath, to help with shower, to assist and leave to the other patient, because hospice considered to be supplemental care. And we would be happy to provide 24/7, but it's not custodial care. It was built by Medicare as a supplemental program to support people at the end of their life at home. But again, it depends on case. I had patient with ALS, very debilitating disease, just 56 years old, and the wife was working 10 days a day, and she could not provide personal care. So patient was by himself sometimes at home for many hours. So our team built the schedule to come every day to help to take care of this patient. And we were lucky to keep this patient at home and not to transfer him to nursing home like he planned. And die at home, actually. So this is pretty much a case by case decision. Nurse can come at the end of life. And again, I had a case, the nurse spent 3 hours holding the hand of the daughter at the bedside of her father who was dying this night. And nobody like cut her visit because it's more than an hour now or more than 30 minutes. It was very important for the family. She spent there 3 hours. Or she can come and the issue, and I was doing night visits in the past, and you come in and everything resolved and patients sleeping like calmly in the bed, and you educated the family and you leave in 20 minutes or 30 minutes. It's again depend very much on case. And if Bridget, you want to, as a social worker, you want to kind of add something, I'll be happy.
Sure. I mean, you gave a great overview. I'll just speak, for these kind of supportive roles that aren't as focused on that patient's medical need. So as a social worker and a chaplain, our services are meant to support the families where they're at, and they are optional, absolutely. If you don't feel like you want that spiritual support, it's not relevant to your family, you feel like you have a really great relationship with a priest in the community, it's optional. We're not going to force any services on you. And certainly, as Maria said, if you need us to come every day, if we're working on something, if our social workers are helping you with an advance directive or funeral plans, we can come or talk with you on the phone as much as you need. Like Maria said, we really pride the services on being available as needed for when things come up and as things change. We might in the beginning, come a few days in a row to really make sure everything's in place, and then come once a week or once every few weeks to check in, and then come a lot in the end. It's really, we want to make sure we're meeting where people are and continuing to have open communication to make sure that as things change, we continue to support.
And if I may jump into just really a perspective as a chaplain in a retirement community with multiple levels of care, that it can be helpful to have the hospice chaplain. It can be helpful to have your clergy, your spiritual support person, to even use both of those services at the same time. I'm remembering a resident a couple of years ago who she regularly came to my Sunday worship services that I led at Ingleside Bible study, those sorts of things. And I remember her family telling the hospice chaplain, you know, we don't really need you. Dana knows her. Dana is the source of support who's able to have these deeper conversations with her. But I also got to know the hospice chaplain and was so thankful for his support of other residents. And he still checked in with her. He still kept that relationship, which was so important, especially when I ended up going on a vacation for a week and a half. And it was nearing the time that she was coming to the end of her life. She was actively dying. And it was wonderful to be able to have his support with the resident, with the patient, with her family, to make sure that they were reconnected before I left. To know that they were continuing to get the support. So from the perspective of an outside clergy person, from the perspective of a chaplain in a community, to have that support of the chaplain agency, the chaplain, hospice chaplain as well, to just know that we all can work together to really support a person and what they need. And also to note that even if someone doesn't really consider themselves spiritual or religious, that a hospice chaplain can help them think about what's meaningful for them, to think about, even on a more secular side, what is some of the favorite music that you would want to listen to in these last months, in these last weeks, these last days? Do you have favorite poetry that you'd want to listen to hear as your loved one holds your hand, whether it's a hospice provider doing it or a family member doing it, just to have some of those conversations and think through how someone can be fully supported throughout their life, and especially in those end weeks and days when it's harder for them to maybe say their preferences, to have already had those conversations so that someone can be truly and fully supported as much as possible.
And I really recommend to meet social work. I always recommend to my patients to meet social worker and chaplain, even if they're not religious or don't want the extra people, because they're all clinical people and they can alert the nurse, they can see the problems going on. It's another pair of eyes and hands, and very passionate pair of eyes and hands, and very full of love, I can say, and care.
I just wanted to add that really when people come on hospice, we look at the patient and the family as a unit. We're really, like, sometimes we're there to help the families more. I'll say as a social worker, you know, I can work just with the daughter if you know, a patient isn't needing any kind of support. So, and we also have volunteers who can be available for kind of continued companionship. They can come read a book. They can come bring a dog. They can do pet therapy. They can come and allow someone's spouse to go run some errands, get a little break. So again, we really are trying to meet all these needs that can come up. And you know, our volunteers are very passionate and always trying to support how we can.
One thing I also wanted to add, it's very common for there to be medical professionals in a family as well. And it is so important for the hospice team to be involved because it allows the family to be a family. I am a business development professional in hospice. I have a sister who's a hospice nurse. And when my mother entered hospice services, it allowed me to be a daughter and not a medical professional as a hospice provider. So a lot of times people don't think that they need all of those different services, but the rounded out support and the entire team, the interdisciplinary team, is intended to support the family entirely in ways that they may not even realize they need.
And two, in the same way as, you know, having that child who's a medical person, I've had a resident who wouldn't call herself Buddhist, but she was exploring Eastern traditions and very much enjoyed meditation. And her son was very much an evangelical Christian leader. And to be there for the family unit as well as for them separately, to be able to help them process what they were going through, to process their anticipatory grief and what that might mean depending on their beliefs. But then also coming toward memorial service planning and helping them with a memorial service afterward that truly honored the person, as well as honoring and supporting the whole family, and being able to remember and honor and grieve. So all of that can play in so many nuanced ways that these professionals can help support.
Thank you all. I mean, I don't want to move forward from that question because I feel like you're all sharing such good information. But just on a practical level, how is hospice and palliative care services paid for? Are they covered by insurance or Medicare? Donna or Bridget or Maria?
Because it is a hospice, a benefit of the insurance, as Dr. Miller mentioned, it is covered by Medicare, Medicaid, most private insurances. There is a benefit for hospice. So Medicare Part A pays for hospice services. Medicare Part B pays for palliative services as a consult type of service, even though it's an overall umbrella approach. But the short answer is yes. And there are some hospices, such as Capital Caring Health, that do actually provide the care and services to those who don't have insurance at all. There are some insurance benefits that some of our community residents don't have access to for various reasons. But if there is a person who is in need of the service and has been referred, and two doctors do agree that the services are necessary, I can speak for Capital Caring Health, we will also provide that service without an insurance benefit at all.
Yeah, and private insurance usually pay sometimes 100%, sometimes 90%. It depends of every private insurance plan. And for sure, like charity cases is, which call it charity cases, if somebody cannot afford to pay for this care and doesn't have insurance, it should be provided.
Right.
Thank you. So a follow-up question to that would be, are there any out-of-pocket expenses that a family member or loved one should expect? And what is actually covered under that benefit as far as services in hospice care? Maria, Bridget, would you answer that question for the audience, please?
Yeah, this question coming from the previous one. So I see hospice as a package of services, and it is, as we mentioned, covered by Medicare Part A 100% and unlimited. Time. We're talking as long as patient eligible. So yes, there is life expectancy 6 months. I had patient who was with us 18 months, as long as we could show that she's eligible for hospice and continue to be eligible for hospice. She was 1.5 years, and Medicare pays for these services 18 months. So for this package of services. And we didn't even break this package because she was really eligible and she was kind of declining step by step. So in this package, we have equipment like hospital bed, oxygen, wheelchairs, walkers, bedside commodes, Hoyer lifts, like everyone has their own need. So we bring this equipment sometimes from the very beginning, sometimes during the journey. And we pick it up when it's not needed any longer. Supplies, like dressing supplies for wounds, for example, like gloves for caregivers, chalks, diapers. All those things are also delivered by hospice, and it's part of the package. I believe it's once a week or once in 2 weeks. Yes, Bridget, I don't remember, but it's kind of delivery from hospice. All these services, all these wonderful team members like nurses, aides, social workers, all covered by this package. Bereavement program, after the death of the patient, a certain months family has a bereavement program coming from the hospice for free. It's also included in this package of services. So medications which are related to the primary hospice diagnosis. Let's say patient came for congestive heart failure. So these medications like diuretics, like medications for comfort, pain medications, shortness of breath medications will be covered by hospice. And we come in for the tricky question, is there is out-of-pocket expenses? And this is case by case. Sometimes family or patient still choose to have some kind of treatment. And this treatment should, or medication, and this medication or treatment should be covered by someone. Medicare most likely will not most of these things because it does not relate. They already paying for comfort. They don't pay any longer for treatment. So hospice paying sometimes. And I give you example, like I had a patient who had dementia, he fell down, he has a laceration on the forehead, it was bleeding. Family called us, we paid for ambulance, patient went to the hospital, patient was in emergency room, they put stitches on this laceration. We paid for emergency room treatment, hospice paid, not Medicare, not family. And we did not approve CAT scan because patient had end-stage dementia. There is no need to do CAT scan and see what happened with this fall. And we paid for ambulance, which took patient back to the facility. So it's just example of what hospice covers. The only thing should be remembered, hospice should know about this. You should call to hospice nurse, and we're available 24/7, or hospice doctor. She will talk with our staff and she will tell you what to do next. And many of the treatments and medications and things approved, sometimes we don't know that the family or patient does this treatment or diagnostic procedure. It could come that patient has to pay for this out of pocket because it was not agreed with the hospice team. And Medicare refused to pay because they were on a comfort page. In my kind of experience, it did not happen often. I'll be honest, because we try not to upset anyone, we're trying to comfort everyone, and we're trying to educate our patients and families that hospice is now goalkeeper and we are available 24/7. And please discuss with us next steps that you plan to do. Bridget, if you want to add something.
Yeah, for sure. The one, the one thing to add on that Maria was talking about is that, we will absolutely cover any testing and treatment for things that are uncomfortable. Like if someone might have a UTI, we'll do a urinalysis and give antibiotics. If we think someone might have pneumonia, we could bring an x-ray to the home to check for that. We are continuing to provide anything that would be uncomfortable. We're alleviating any suffering, of course. The other thing that can be an out-of-pocket expense is caregiving at home. So when you're on hospice care, we come to wherever you are. If you're in a nursing home and in a private apartment, our team will come see you there. And like Maria said, we have home health aides who can come a few times a week and help with the shower and some personal care. But I wish we could give 24-hour care for everyone in their homes, but unfortunately it's not part of that hospice benefit. And so families, we will have to provide that care or pay someone, a caregiver, maybe through an agency or our private caregiver, to be in the home if they need that. Some people do have long-term care insurance and can get that covered through that, but it is unfortunately not covered by the hospice benefit to have aides for long periods of time in the home.
Thank you for being so thorough to each of you and Bridget. Donna, Bridget, Maria, again, another kind of hospice specific question in terms of training, being able to be provided to family members. So Bridget, I think you were just kind of leading into this by talking about caregiver hours. Hospice doesn't provide a 24/7 CNA. So can some of those skills be trained to a family member, or what does that look like?
Sure, I can briefly, I think might make more sense to have a nurse get into the details, but we're there to try to make this families feel as confident to be able to do this as possible. It can feel a little overwhelming. What do you mean I have to know how to give medication? Like I have to figure out how to do this by myself, and you're not alone in this. We're here to help you feel confident, that we teach, how to give medication appropriately, and we're always available by phone or to come out and reteach. There's no shame in having us continue to support you in that way. And we can teach, especially like our home health aides can help teach how to kind of reposition, and we can have a physical therapy consultation to come and help teach families how to, most safely get in and out of bed. And certainly whatever we can do to help people get more accustomed to the declines that can commonly happen as someone gets closer to end of life.
Yeah, I just want to add that my job, I'm usually talking with potential patients. So I'm going to hospitals, I'm doing evaluations, and I see my role not only to give information about hospice, I see my role like to do this, to help with discharge planning, because people and families are very lost sometimes what to do next and what kind of options they do have. And I probably have more, at least I try to find more time to like hours, sometimes more than 2 hours, to talk with the family. What options do they have? That's what happens if you go to rehab facility without hospice. This is what happens if you go home and you have to hire home aides. This is what your option if you go to assisted living facilities. Sometimes people don't think about these options, and there is a lot of options in our county, and some of them affordable, much more affordable than out-of-pocket pay, let's say, for the skilled nursing. So I also referred to some assisted living facilities, and that's what will wait you if you go with hospice. So like when people and they are very, and most of the time they're very thankful for this information, because now they see different roads to go and to choose. And this is how we do our education as well from the very beginning. And people very thankful actually about this, because it makes it much more clear what will be consequences of every step. This is about education as well.
Does anybody else have anything to add before we move on? Because I think you guys have done a wonderful job of really outlining the type of education and support that can be expected during when someone does elect the hospice benefit. And Donna, you made an excellent point when you discussed when someone, elects the hospice benefit, the hospice care team is there to provide care and support, allowing the loved ones to be, a daughter, be a son, grandchild, or whatever. So what kind of respite is available for family members and the patient, and under what circumstances? And are there any requirements that need to be met first?
So with that, caregiving, just to acknowledge, is a beautiful thing. However, it can be very exhausting. And some people don't recognize that until they are in the throes of providing care for a loved one. And it renders that person lots of different emotions. With that, the hospice benefit was actually designed with that in mind as well. There are 4 levels of care that are a part of the hospice benefit. Not to get too deeply into it, but there's routine level of care, which Maria talked about when the case manager comes and the plan of care is established and it's already noted how often we will be coming, et cetera. Then there's another level of care, which is called crisis care, when there is a symptom that cannot be managed with a regular routine visit. Then we bring in nursing care for at least 8 hours to try to mitigate that symptom, make that person comfortable keeping them in the home. There's also a 3rd level of care, which is general inpatient level of care, which takes that person into a hospital type setting for hospice patients that allows us to give them that focused care that they would receive in the hospital if they went to a hospital. But it's designed to keep the hospice patient out of the hospital, but to still receive that acute care for symptom management and then get them back home to the place where they live. The 4th level of care is the respite benefit. And that is designed to ensure that a caregiver or the person who is providing the care to a loved one under the hospice benefit is able to have time for restoration and time to just be themselves and travel or whatever is needed for the caregiver to be able to reset and continue to provide care for their loved one. It's up to 5 days at a time that's covered by the hospice benefit, where the hospice agency is partnered with other locations. Sometimes they have an inpatient unit, just depends on the agency, how the respite care is provided, but it does allow for that family to have their loved one cared for in a setting that is away from the home, allowing that loved one to still have 24-hour care paid for by the hospice benefit, but it gives that family member the ability to reset. We've had people use the respite benefit just to be able to sleep uninterrupted because they're caring for a dementia patient who sundowns and they can't get rest because they're, constantly worried about what's going to happen and they're up. So, there are many reasons. We've had families take advantage of the respite because they had a loved one who was graduating or getting married and their person who's receiving the care is unable to travel. And of course, life continues whether you're giving care for a loved one who is ill or not. And because life continues, the benefit is built so that the caregiver can still give care, not just to their loved one, but to themselves as well.
So go ahead. So a related question, in the sense we just talked about respite care for the caregiver, is there an inpatient unit where a patient would go who is admitted to hospice? I mean, we've talked about hospice at the home setting, but if it can't be managed at home, is there an inpatient unit? And then are there certain criteria that need to be met to be able to be admitted to this? So Donna or Maria or any of our hospice representatives.
Yes, inpatient hospice, it's, that's why people thinking that the hospice is a place, that you take someone to the place. And I can blame Great Britain for this, because in Great Britain, this hospice was built in 60s as a house. And still, if you're watching the British movies, you see that person at the end of life, last like weeks of life or months in life, go packing, taking the luggage sometimes and goes to this house to die. It's not in America. It's not in not in United States. United States inpatient hospice, it's just for those patients who have acute symptoms to be managed. They can be in excruciating pain or shortness of breath, and we cannot manage it at home. We cannot wait until give pill and see how good they are, after this pill, are they better or not? We don't have time for this. We want to relieve their suffering. So that's when the hospice agency taking the patient to inpatient hospice. Some hospices we do, and I believe Capital Caring, they do have beds in the hospitals where they can manage the pain or acute symptoms. Some hospices has their own houses, but again, the main thing to remember, it's not because family cannot take care of the patient and cannot change the diaper or cannot, don't have space for the patient. It won't be paid by Medicare, it won't be approved. Somebody has to have very excruciating symptoms to be taken under control to go there. And as soon as the agency, hospice nurse, hospice doctor, agency will find the way to manage this symptom, and patient has some relief, they have to be discharged from this inpatient unit and go back home, wherever it is, nursing home or just home or assisted living, but go back to routine hospice care. And Donna, thank you so much for covering all those 4 levels of care. It's so important to understand.
And I totally agree with you, Maria. A lot of people do believe hospice is a place and they say, well, we're going to send the person to the hospice. And of course, that would be wonderful if we had that ability to just have a home where people can just transition at the end of life because their family can't take care of them and those kinds of things. But specific to what Maria said, the inpatient level of care is specifically for pain and symptom management related to the disease process that that person is under care for. And Capital Caring Health does actually have an inpatient unit. We have a 10-bed inpatient unit on the campus of Sibley Hospital. And then in Aldie, Virginia, we have a standalone location that is an inpatient level of care, still not a residential care facility, still only for the management of pain and symptoms with the idea of getting that person back to their routine level of care where they live. So it is, again, the criteria for a symptom that cannot be managed in the home, and with the focus of getting that managed and getting them back to the routine care.
And the number of people who really will need this inpatient management, it's really like a very small percentage. I can say like 99% of the people will be comfortable at home on hospice care, and probably just a very small amount of people will need inpatient hospitalization for symptoms management.
What I also know from being at a community like Ingleside or Rock Creek, I know of independent living residents who go on to hospice and very much stay in their independent living apartment, getting extra aids, getting extra support, as well as, of course, all the support of hospice. And it's very comforting for them to be able to stay in their home, to stay in their place, surrounded by their belongings, their routine, even as the routine changes, to know that they're in that comfortable space for them. Then there are others who know that maybe having a lack of some family support, or even having tons of family support, knowing that being able to go to skilled nursing and continue to get the hospice care there is the right decision for them, to have round-the-clock care, even as it's not acute care, but to have that combination of hospice and a skilled nursing facility provides peace of mind for them. So there are so many options for people, especially when they have those resources, to be able to choose what they want to do toward the end and have support in a variety of ways.
So now I want to pivot a little bit, and this question is directed to Dr. Miller and Maria. What happens when someone dies under hospice care, with or without hospice care? If you guys can give us, our audience, a little comparison of the support and things that hospice provides when someone dies, and then what that looks like if, you know, someone dies at home and they're not under hospice care.
Well, I will go first because it actually is important where you're living at the time that you die. There are differences between Maryland and the District of Columbia for this group. And, you know, just a hospice, and the hospices actually some hospices cannot cross state lines, such that just a hospice, and correct me if I'm wrong, only can operate in Maryland. And I know that Capital Care operates in several locations, but the district only has a couple of hospices. So if someone dies and they're under hospice, then you call the hospice nurse. You don't call 911. You call the hospice nurse, because that person has to be what's called pronounced. A nurse or a physician, but a nurse has to come and do an exam and certify that the person is without vital signs and that the person has passed. And the hospice nurse will do that 24/7 where the patient is. Also, when you're under hospice, of course, you've had the social worker. We've talked about the team support, so that by this time you've been able to just have already in place the end of life decisions, like whether to do CPR or not to do CPR, whether, what funeral home you need. And it's, I think, very comforting for the families. It's certainly personally for myself as a physician daughter whose mother passed away this past June during COVID. It was very helpful to just be able to call the hospice nurse, come, they took care of calling the funeral home. They took care of everything so that we as a family could just do the grieving, and then the funeral home comes and takes the body, and we'll set up a time to meet with the family to determine more things. So they try to make it as very supportive and easy for the family at the time, at such a grief-stricken time. If someone dies at home, you also don't have to call anyone right away. A family can sit with the body if they want to. If there's religious things that need to be done at time of death, you can do that. You can call the hospice nurse, you can call the clergy and that type of thing. And then when you're ready, the funeral home can come and pick up the body. So it can provide a lot of support. If you have someone that just suddenly drops dead at home, or doesn't wake up in the morning, or starts complaining of chest pain, and you call people will generally call 911 if they're not under hospice. So if you call 911 because you're not under hospice, then oftentimes the fire department comes, and then the EMS people come, and the patient still has to be pronounced. Now, sometimes the police will get, actually, my experience, which I admit is a little bit old in Washington, D.C., is it becomes a homicide investigation if someone dies at home, regardless of the age. Because I had a 100-year-old person that died at home, and I ended up going and pronouncing her myself just to try to help the family so you didn't have to deal with the police. And then you talk to, if you're hopefully you've been seeing a physician and such, and then the physician can talk to the medical examiner, and then the body can be released. But it is, or EMS may have to take the body to an emergency room or something like that so that the person can be pronounced. So it's much more traumatic for the family if the person is not under hospice, because of having to involve in EMS, and because of having to involve the police and the medical examiner and such, and often because people haven't thought about the funeral homes. So Maria, do you want to add anything, or Donna?
No, I think you covered this very good. For me, just death, it's not like one time, like 1 second event or 1 minute event.
Yeah.
It's like everything what happened before, like with all this support, which we talked all this hour, comfort, hopefully nice time between family members. And I had experience when two of my friends were, and actually other culture like Russian speaking guys, were losing their parents, and this education when they were calling me privately, what's going on next, what will happen next. I was sure that it was not too much helpful, and it completely was kind of, otherwise. So they called me after, and I become very close friend of one of them, which we were just co-workers before, because she felt that she accomplished everything. Like daughters felt that she used every minute of last week as it's supposed to be because of some education that we got from us. And I told, I agree, ask her one, are you grieving badly? Because she lost her parents like 2 weeks apart, both. She told, no, I feel like I accomplished everything, like that I did best what we could do. So I really feel very rewarded. Just educational and guidance, like very simple, like phone calls, made difference of probably many months or many years grieving process. So yes, and I was once when police came in Montgomery County, and because I came to do admission for the patient, and patient died before I admitted, and we did not have a time to sign CPR, no CPR, and I called police because I was there. And even for me as an official person, as a nurse, it was pretty much stressing, because they have to come with the harsh questions and investigations, and wife is crying because she's grieving already, pain, and at the same time the police like investigating, asking billion questions, trying to start CPR, although I'm trying to stop it, and they have already most signed, but doctor did not sign the no CPR order. And that's why they have to do it, because it's not yet official. Yeah, it was traumatic experience. I still remember this because I had a lot of patients to admit, and this case I do remember. Thank you.
So Dr. Miller and Maria, you lead us right into some of our final questions as we wrap up this time together. And I know one of them is about having a DNR or a do not resuscitate in place. And one of the other questions is just about the grief counseling and spiritual support to be offered. And again, reasons to have maybe hospice care in place. So I don't know if Dana, you want to address this, or Bridget as a social worker, but just talking about grief counseling and the spiritual support that is so necessary in this season.
Bridget, do you want to start and I'll jump in after?
Sounds good. So in terms of these kind of counseling and emotional and spiritual support for the families, we start as soon as we meet people to help them cope and kind of process the situation and help with what we call anticipatory grief. As a loved one, you're witnessing and acknowledging that someone that you're close with and very closely connected is coming close to the end of their life and are going to die, and that's very difficult to cope with. So you're already starting to process that grief even before you lose that person. And so we're there to help you make sense of this and be as prepared as possible. You're never really prepared for that moment when it comes. It's always going to be difficult. But trying to have that counseling for that anticipatory grief so that it's not quite as traumatic of an experience. But then following the death, we certainly provide bereavement support. There's bereavement counselors and coordinators that are there to provide that individual support, as well as support groups, which can be focused on the loss of spouse group or loss of parent. There's several different groups through the hospices, and they're all completely covered free of charge. And the groups you don't have to have a loved one on hospice. You can have any loss to participate in these groups free of charge. And the bereavement, like one-on-one direct support is available for 13 months following the death. And if throughout our process of getting to know these family members, if it seems like they're really struggling and could use more focused treatment and support, we are happy to connect people with individual counselors in the area so they can get that, weekly hours in and, ongoing support as needed. So we really want to make sure that, it's very normal to struggle with watching and acknowledging that a loved one will be dying soon, as well as coping with after. And so we want to be as supportive as possible.
Yeah, and just sort of following up on that, as a chaplain in the retirement community, and then my role is different than being a hospice chaplain in so many ways, but still interacting with them toward the ends of those times. A lot of it comes into that anticipatory grief, that planning ahead, that helping the resident, the family know what they want their plans to be when they die, helping them to know what they might want to have for a memorial service, how they want to be honored, how they want to be remembered. And for some family members, it's really helpful to be able to walk through all those processes and steps, and it helps them grieve and process, to have something to focus on. Others need more of just an active listening presence to be able to share stories and memories, and just have that release of being able to connect with someone with all of that. So for the chaplain, for the support services, it can be any number of things, from being that listening ear, that active listening ear, that presence. For others, it can be a couple of counseling sessions, but then also knowing that we want to connect them with a support group. We want to connect them with more intensive support, and help have that list of resources in the community and resources that they can follow up with. And then from a chaplain's perspective as well, it can mean following up with a family with grief care. It can, in these COVID times, be a Zoom call, or that family member lives on the other side of the states, but with the Zoom, at least we can see face to face as we listen and process together as we plan a memorial service. For people on or closer to campus, for us, being able to give even just a grief care bag that has some snacks and water and a granola bar, so that in those more immediate moments, they have a little bit of sustenance as they're processing and going through all these different things. But again, helping plan or support a memorial service, either gathering people together or a gravesite service, smaller and with family, just to be able to really honor someone in those last moments. Right before the call, I was stopped by the spouse of a resident who had died within the last year, and talking more about the plans of what we can do with the ashes, how we can honor that person and slow down, and letting her know that I didn't have much time to talk, but that we'd follow up in the coming days, and we'd come up with a plan so that they would be honored. And with people on campus too, being someone who puts up frame notices so that other residents can know what's happening with a person, their family's permission, to be able to put up a frame notice to let people know in memoriam, to help put up obituary notes so that the community and further on can grieve as well and continue to support. And also, one of the things we do is often get a sympathy card that the staff can sign and share memories of their loved one, of people that they cared for. It helps them process, but also helping the family know that their loved one was cared for by people that got to know them quite personally. So being able to support the family and the whole community in that way.
Thank you, ladies. You did a great job of really explaining that this care and support does not stop after someone dies, and that, you're continuing to still provide touch up with the family, and still, provide support long after their loved one passes. And so I would like to close with Dr. Miller and Dana, hopefully giving us a brief overview of death with dignity. I see that it's already been asked in the questions or the comment section, so I will turn it over to you guys.
Thank you. So death with dignity, I have to admit, is not something that I have a lot of experience with, but it's the concept of, again, pretty much an American concept of personal liberty, and personally being able to have control of what happens to your life and what happens to your body. And there are people that feel that if they have some type of terminal illness or condition that will have a lot of suffering. And when they get to a certain point, they want assistance in ending their life so that they don't have to continue with the burden of suffering, and that others around them don't have to suffer. So Montgomery, Maryland does not have a Death with Dignity Act. This is definitely a Washington, DC situation at this point in time. There are a few other states that do have it as well. Donna has a little bit more experience with this than I do, but in DC, if you go on, we'll include this maybe with information that's shared on the recording, but if you go on the Department of Health website or Google Death with Dignity in DC, there is a lot of information that goes through all the details. In the District of Columbia, you have to have a consult with a physician that's certified to do Death with Dignity. I had a patient that Dana probably knows at Ingleside Rock Creek who has initiated this and has met with Dr. Roth, who's connected with GW and such. You have to have 2 doctors that certify that the patient is capable and understands the decision that they're making. And the patient is also under their hospice benefit at this time as well, because they are near the end of life, so they qualify for their hospice benefit. So this is being done in conjunction with hospice. And Donna, I think I'll let you take it from there because I'm not don't have a lot of experience with it.
It is a larger conversation, I know, than what we have time for, but it is something that residents can elect to do in the district. As it relates to the hospice involvement, Capital Caring Health is committed to supporting people through the end of life as they die naturally. We understand the hospice does not hinder or hasten death, but we are certainly partnered with those who are moving toward the end of their life. We don't participate in the Death with Dignity movement in the sense that we offer it, but certainly a person who is at the end of life wanting their hospice benefit can still access it. And when and if they decide to go in that direction, there's a different conversation.
I was just going to say, as a chaplain, as a spiritual and pastoral care professional, to iterate that my role in knowing for support people, professionals as well, my role is to support the person, the patient, the resident, and his or her needs, wants, tradition. It's not about my faith and imposing that upon someone. It's about supporting them in their choices. So sometimes that might mean active listening, hearing what they're wrestling with, giving them non-judgmental space to explore what they're going through. But ultimately, it's about what that person needs and wants, ultimately about what's supporting them and what's meaningful for them and supporting them in their decisions.
I know we're running close on time, and I'm happy to, it's saying in the chat that our contact information is being provided. So I'm happy to talk with anybody a little further about this if they want to know personal experience. When I worked in DC, I did have probably 6-8 of the patients I was working with utilize this program. And just briefly, the person who's wanting to use this program does have to have capacity. They have to decide this for themselves. And like Donna was saying, the hospice physician wouldn't be the one who would be doing that program and prescribing that medication. It's a separate program from hospice. You can have both if you want. That's completely up to you. And a lot of people find it comforting knowing that that is an option that they can have at some point should they feel that their quality of life not be acceptable to them. And they can have the medication and choose not to take it. I've had that a handful of times, that they just knowing that that is an option can make that end of life feel easier. And so, yeah, so I'm happy to talk further. I know it's a very big topic with a lot of nuance. So.
All right, so I think that was our panel questions, and we're so sorry that we ran over a bit, but we do have a few questions besides the one about death with dignity. Someone wanted to know, what does active dying mean? I guess this was referenced earlier in the panel.
Dr. Miller, I feel like we should refer to you for that.
Active, well, or Maria. So active dying is when people are at a point where their heart and their lungs and their bodily functions are deteriorating to the point where death is inevitable. It can be anywhere from minutes to hours to, at most, a couple of days. And it's at that point, and in my experiences, all the hospices have written materials that they give to the families that have a lot of these things delineated and give examples to help the families know what to do when their loved one reaches this point and what to expect. Unfortunately, most death is often, I don't want to say messy, but death is not quick and clean necessarily the way we would like. I mean, people do sometimes linger and, taking shallow breaths, not eating or drinking anything, and it can be very, I've been on both sides of the bed for this, between my own family and between helping others. And it can be very difficult to watch someone actually in the dying process. But my definition of active dying is when someone is in the actual dying process at the very end.
Okay, thank you. Someone also wanted clarification from you about, well, that you mentioned 6 months or a year, and others have mentioned 6 months as the hospice requirement. So I guess just having some clarity about.
Well, what I didn't mean to be with, so what it is if the disease runs its natural course and you expect that someone is going to live on average for 6 months, which can be, as Maria says, the person can die right at the time of admission, or the person could be on for a year. I mean, it's going to average out to 6 months. But what you have to understand is, because it's an insurance benefit, the primary care physician and the hospice team has, the patient has to be recertified every so often, okay? And if someone has been on hospice for more than 6 months, then they have to get recertified every 2 months. And there you have to certify that the patient has this symptom or this marker or this acceptable area has been checked off that makes it such that the person can continue with the benefit.
I just want to add that this is not a bother for the family or patient. So the hospice team will do assessment, will discuss with the doctor, and let usually the family knows. Sometimes we let them know like a week or 2 weeks ahead that this their loved one is very stable or getting better, and according to Medicare regulations, we have to stop the services. And very often, sometimes like it's time to stop the services and patients start to decline again, and we don't stop the services. So we in a JSSA hospice, we have transitions program, which is post-hospice or pre-hospice. So if someone discharged from the hospice because they are better or stable or not qualified any longer, so they have this program, transitions free of charge, not medical, it's community program where we can continue to follow what's going on. And if patient becoming, again, have some kind of decline or functional decline or disease like progressing, and we can take back to the hospice services. So 6 months is just kind of prognosis, but it can be less or more.
Yeah, doctors are not always very good at prognosticating things. It's very, very difficult. This is still very much an art, and it's very difficult to prognosticate these things. And I just wanted to mention that, if just because someone doesn't meet the strict criteria for using the hospice benefit, then palliative medicine still can be provided. It just will be provided through their primary care doctor or through their whatever specialist is involved, or it will be, and then you can also have these often non-medical volunteer support systems like transitions for JSSA Hospice. I know Montgomery Hospice has a similar thing, and I'm making the assumption, Donna, that Capital Caring has also these kind of transitional non-insurance based support that provides just at least emotional and volunteer support.
All right, thank you for all that information. We have one more question real quick, because I know we're over. Someone would like to hear more about the volunteer opportunities from Donna or anyone else that you mentioned about for those who are in the active stages of dying, people who can help with that.
There are volunteer, we of course, JSSA included, every hospice has the opportunity to have volunteers that support those who are using the hospice benefit, whether that be in a facility or their home setting. It's a program where the representatives of that organization who are volunteers are trained to help and to field the services that are being requested from the volunteers. So we do have those opportunities available in every area that we extend service. We're in the district, we're in Northern Virginia as well as Maryland. And I did receive, Bob, your information, your request. And so I sent over my contact information for volunteer opportunities. Our volunteer coordinators and directors will actually reach out or can be contacted for more detailed information about what the specific needs are, what your specific idea or request to volunteer, because we do have people who have different ideas of what they want to offer from a volunteer perspective, which can be used entirely across the board. So we do connect with those who are interested, identify where they can be used best, and move forward with the training and the potential to support those at the end of life.
All right. Well, I just want to thank all of our experts on the panel. Gave so much great information. I also want to thank Angelique and Kiersten for bringing this panel together and for it's been wonderful to work with you throughout this series. And thanks to everyone who turned up today to listen. We know it's not the easiest topic, but we felt it was very important. And this is information people need to know. We have recorded it. We will send that recording out along with the other information next week. So thank you everyone again, and have a great rest of your day.
Have an amazing weekend. Thank you.